Hi, I am so delighted to meet you in the 17th session of JIP Academy Diabetes. I sincerely hope that you have been immensely benefited with the programs what we have reached out so far. So, this program also definitely will enlighten all kind of diabetic and that's allied healthcare knowledge. 60 years old male patient, a known case of diabetes for past 12 years with diabetic retinopathy for past 2 years has following glycemic and lipid profile. Patient's fasting blood sugar 190, postprandial through 245, HbA1c 6.8%. Patient's renal function tests are normal, and if you look at lipid profile, the total cholesterol is 198, triglycerides so very huge 486, HDL on the other hand it is very low, non-HDL 170 and LDL 68 milligram and VLDL that is 1/5 of triglyceride is 87.5 milligram per DL. So patient is on tablet glimepiride 2 milligram morning one and night one and tablet metformin 500 milligram and morning one night one. Let us come back to the case study. Okay, so how will you manage in this patient? So as we have emphasized on so many occasions, when you look at fasting and postprandial, look at HbA1c as well. In that way, fasting sugar around 190, postprandial 245. So when someone has 245 on the day of testing, our expected HbA1c, I mean if patient has maintained same 245 milligram on every day for past couple of months, then he would have maintained HbA1c somewhere around 8%. But HbA1c is only 6.8%. So what does it mean basically? So that means for past 3 months he has been maintaining very good glycemic control as evidenced by HbA1c 6.8%. So anything HbA1c less than 7% always indicates that patient's blood sugar level somewhere around 140-150 milligram. But only on the day of testing only his blood sugar level gets elevated. So what does it mean? That means for past 3 months his blood sugar level of course and his medicines match with each other. Just a few days before probably the blood sugar level might have shot up. So that means you have to scrutinize the patient in such a way that whether patient has discontinued medication just 2 to 3 days before or whether the patient was on non-diabetic diet resulting in this high fasting postprandial sugar. So usually when HbA1c is normal, that means you must be very happy. That means your treatment regimen is fantastic. That's the reason for past 3 months his blood sugar level has been under control. When fasting postprandial is only on the higher side, on the particular day only it is on the higher side, that means you don't need to revamp the medication or you don't need to change the medication abruptly. Instead, you have to ask or you have to interrogate the patient whether patient has discontinued medication couple of days before or patient took non-diabetic diet like including taking sweets and all kind of sugary drinks and so on. So if patient says that, yes doctor, I took non-diabetic diet, then I discontinued medication, then I was on irregular treatment, that means you don't need to change the medication because your medication have proved that his sugar has got controlled with your existing medication. So once patient rectify the error, whatever he accomplished, then what happens? Then everything will get under control. So this patient can repeat his sugar level after 15 days with religious diet and sincere drug adherence can result in good glycemic control. So whenever HbA1c is normal, then only fasting postprandial is on the higher side. don't make any attempt to change the medication. That's very, very important. But there is a caveat in that, in my statement. Suppose patient says that I didn't take any medication for past 3 months at all. Suppose if he says something like this, then what would be your response? So when patient says that I had been taking medication just a few days before, then that's a different story. Doctor, I didn't take your medication for past 3 months. Then when someone didn't take any medication for past 3 months, then HbA1c must be on the higher side. Then still HbA1c is on the lower side. Then how will you interpret? Then that is called false lowering HbA1c. So that means, what is false lowering HbA1c? That means in the presence of high blood sugar on every day, maybe couple of months also, but your HbA1c results is erroneous. There are few conditions where, in spite of maintaining high sugar for past 3 months, 300, 350, but still your HbA1c may be very low. That is falsely low. So what are these conditions where patient may maintain high sugar level 300, when you take CBGs 2 days once, 3 days once, 300, 350, but if you do HbA1c, but may be very low. So what are the reasons? Yes, there are couple of conditions which can produce falsely low HbA1c in the presence of high blood sugar on every day. So what are those conditions? The most important one is hemolytic anemia. Any patients who presents with high blood sugar as evidenced by repeated CBG reading or continuous glucose monitoring, that is called CGM. When you do CGM, all the 10 days, 15 days sugar level around 300, 400. But if you do HbA1c by HPLC method, it will show lesser value. Then what are those conditions you can explore? The most important would be hemolytic anemia. So when patient has hemolytic anemia, what happened? The RBCs are destroyed before its destiny. I mean, usually RBCs will be destroyed after 120 days. In hemolytic anemias, what happened? For example, in thalassemia and sickle cell anemia, G6PD disease, those hemolytic anemias, when they inherit these hemolytic anemias, what happened? These RBCs will be destroyed within 20 to 30 days. So what happened at the time? These RBCs survive only for shorter time in those patients. So the shortened lifespan RBCs will get glycated only for short time. For example, he may maintain sugar level 300 milligram, but if the 300 milligram sugar, if it gets attached to a RBC, which lifespan is 120 days, then your HbA1c may be 10%. But you are maintaining 300 milligram of sugar, but this 300 milligram sugar gets attached to the RBC, which survive only for 30 days. So it will show HbA1c only 6.3%. I hope you understand. So one is hemolytic anemia, and second one, suppose if patient has received blood transfusion, so the patient's original older RBCs may have high sugar value. That's why that older RBC's HbA1c value may be 10%. But when you transfuse the blood which contains the RBC with normal sugar level or normal HbA1c, when it dilutes the existing patient's recipient's blood, so what happens? Your HbA1c will be falsely low. During the time of erythropoietin therapy, when you give erythropoietin for RBC production, okay, what happens? Erythropoietin will produce new RBCs. So new younger RBCs will have lesser exposure to the high glucose rather than the older RBCs. So your HbA1c may be very low. So when someone has high blood sugar, you expect high HbA1c, but in the presence of increased fasting postprandial sugar, but HbA1c is normal, you must be happy, provided patient says that he discontinued medication just few days before the testing of fasting postprandial, then everything would be over. But if patient disagrees that no, I discontinued medication long before, but you expect HbA1c would be very high, then you have to think of these conditions. But generally that may be a very rare occasion, but generally someone has very high fasting postprandial sugar, but only HbA1c normal, then this HbA1c normal level indicates for past 3 months sugar level very normal, then please advise the patient, you rectify the error, then probably your fasting postprandial would be normal. Then I am going to leave that glycemic profile now. Now we will look at the lipid profile. If you look at the lipid profile, the most important point that tempts us is high triglyceride. But when you look at lipid profile, especially in the case of diabetic, the most important primary target would be to look at LDL. So the bringing down LDL only favors cardiovascular events reduction rather than addressing high triglyceride. Whenever you focus lipid profile, look at LDL first fix up the LDL target. So what is the LDL target in this patient? So this patient, a case of diabetes for past 12 years with diabetic retinopathy for past 2 years. That means for past 2 years, he has suffered one organ damage. Any diabetic patient with either one of the organ damages, including retinopathy or peripheral neuropathy or nephropathy, then the target LDL level would be less than 50 milligram according to Lipid Association India guidelines. So any patient, a newly detected diabetic, deserves 10 milligram statin at least according to the guidelines proposed by Lipid Association of India, because Lipid Association of India considers our Indian populations are more vulnerable for getting cardiovascular disease as compared to Western counterpart. So they have imposed very stringent rules. So any diabetic patient, this patient always poses a big threat to their life in the form of cardiovascular disease. So this patient should be administered statin irrespective of LDL level. That is the dictum according to the guidelines of Lipid Association of India. So any diabetic patient, whether 100, 95, they deserve one statin 10 milligram. But diabetic patient with 2 or more cardiovascular risk factor, for example 50 years old male patient, diabetic patient, with either patient has hypertension or history of smoking or age group more than 45 years in male and more than 55 years in female, low HDL, either one of these risk factors, 2 risk factors with presence of diabetes, their LDL target would be below 70. But diabetic patient with one organ damage, end organ damage, their lipid level should be, the LDL level should be less than 50. In that way, you can't be content with 68 milligram of LDL. This LDL 68 milligram should be brought down below 50 according to the guidelines, because patient harbors one organ damage already. Patient may go for a few more organ damage in days to come. So you have to introduce statin, because statin not only reduces LDL level, it offers pleiotropic effects. So what is pleiotropic effect? So pleiotropic effect means other than reducing LDL, statins are considered as anti-inflammatory, anti-thrombotic. It stabilizes the atherosclerotic plaque, by which it prevents rupture of atherosclerotic plaque, and it improves endothelium. Because of these reasons, statin considered is considered as one of the potential drug in preventing or reducing the cardiovascular event. So, because of which we introduce LDL, because here a diabetic patient with one organ damage target LDL is below 50. Once you introduce statin, repeat lipid profile after 4 weeks, because statin can reduce LDL and as well as triglyceride. So, statin can reduce triglyceride below, can reduce triglyceride by 15 to 25%. So, repeat a lipid profile after 1 month, ensure that LDL has gone below 50, then whether triglyceride has come down with the introduction of statin, just check it. Then after a month of lipid profile reveals LDL has come down 50, okay, less than 50, but triglyceride level doesn't come down substantially, then probably you have to target triglyceride with the medication which simply focus on TGL reduction. In that way, when triglycerides doesn't come down, then you have to explore secondary causes of hypertriglyceridemia. Secondary cause of hypertriglyceridemia is, one is diabetes, we have addressed diabetes, and hypothyroidism, check thyroid profile if there is any hypothyroidism, and chronic kidney disease, they may harbor hypertriglyceridemia. Check the personal history, alcohol consumption will encourage hypertriglyceridemia. So, after correcting the secondary cause of hypertriglyceridemia, including the obesity and high carbohydrate diet, if you take refined carbohydrate, if you take more fructose containing diet, because fructose will be directly entering into the liver, producing the fatty liver, that is very notorious than glucose. That is the reason when you cut down the white sugar, you will reduce your the intensity of fatty liver, even you can reduce weight substantially, because fructose can produce weight gain very easily, because fructose will enter into glycolysis pathway, then it will be directed towards acetyl-CoA. Acetyl-CoA will lead to fat formation, that is called de novo lipogenesis, the formation of formation of lipids from excess carbohydrate. So, when someone presents with a hypertriglyceridemia, ask the patient to avoid refined carbohydrate, processed carbohydrate, the fructose containing all kind of artificial fruit juices, then better to avoid white sugar, because it contains sucrose. Sucrose is nothing but glucose and fructose. So, this patient, despite introduction of statin, the repeat FLP reveals triglyceride level still doesn't come down below 150, that is the target. This triglyceride should be aggressively treated, because this patient already harbors one organ damage. This patient may go for cardiovascular event anytime. So, not only addressing LDL, the addressing triglyceride also important once LDL is brought down below the target value. So, what are the drugs that are available for triglyceride? One, there are 3 drugs that are available for triglyceride reduction. One is icosapent ethyl, and second one is fenofibrate, and third one is saroglitazar. So, how these drugs act and how will you choose these drugs? Among these 3 drugs, icosapent ethyl and fenofibrate and saroglitazar, among these drugs, icosapent ethyl has proved that it is capable of reducing cardiovascular event. So, how these act basically? So, icosapent ethyl basically it inhibits triglyceride production. What about fibrate? Fibrate stimulates lipoprotein lipase enzyme, resulting in triglycerides breakdown. That is very, very important. Icosapent ethyl inhibits triglyceride production. Fibrates increase the triglyceride hydrolysis and fatty acid oxidation as well. Saroglitazone, basically it is a PPR alpha and gamma stimulator. Again the purpose is nothing but it is triglyceride breakdown and the fatty acid should be oxidized rather than to be stored. That is the purpose. So, if you want to reduce triglyceride and cardiovascular event, then the best drug would be icosapent ethyl. So, icosapent ethyl should be given 2 gram twice daily, but it is quite costlier. But among these drugs, this is the only one drug is able to prove that it is able to reduce cardiovascular event. Fibrate and saroglitars are capable of reducing the triglyceride number, but it is not translated into proven clinical outcome. That's why we prefer nowadays icosapent ethyl 2 gram twice daily when you witness triglyceride 300, 400 when it comes to CV reduction. That's very, very important. So, icosapent ethyl, the most important, two important side effect would be atrial fibrillation. When someone has past history of atrial fibrillation, you should exercise caution. It may aggravate bleeding risk. So, someone has, if they have newer oral anticoagulant or platelets, then I think that you should be very mindful about that. Otherwise, icosapent ethyl, definitely it is much safer. Very rarely 1 in 100 patients treated with icosapent ethyl may get the onset of gout. So, please ensure that patient doesn't have history of gout and the monitoring of serum uric acid is warranted. So, this patient deserves icosapent ethyl 2 gram twice daily. And another important is we don't have much medication to increase HDL level. So, the best drug would be niacin, that has been abandoned nowadays because of numerous side effects. Now, the fibrate which can reduce triglyceride while increase HDL. So, it has some potency because the HDL, it promotes HDL formation. And another important what you have to remember that when you reduce triglyceride level, then automatically HDL level will go up. That's one inverse mechanism is there because when triglycerides are metabolized, the HDL will become very smaller. So, HDL catabolism would be much higher. That's why they say that when you reduce triglyceride, automatically HDL catabolism will become slowed down, then automatically HDL will stay longer in our circulation. That's a different story. So, the take home message would be when you have high fasting postprandial in the presence of normal HbA1c, think of discontinuation of drug or non-diabetic diet just a few days before, correct the error, then probably fasting postprandial will be brought down to normal. But if patient says that all the days whenever my repeated CBGs are very higher even for past 3 months, but HbA1c is very normal, think of very rare false lowering HbA1c where, for example, hemolytic anemia patient, they may have sugar level 400, 300, but HbA1c will be much lower. You should think of. And another important is whenever you look at the lipid profile, first you bring down the LDL according to the LDL target based upon the category of the risk groups, and second one, then you target the triglyceride. The out of 3 drugs, the most important, the preferred drug would be icosapent ethyl ether when it comes to cardiovascular reduction. So, I have fervent hope you have understood much, then probably you just translate whatever the clinical points I have enumerated into a prescription. Thank you.